Imagine a quiet night interrupted by a sudden severe heart attack. The room is dim, a single lamp casts long shadows, and someone becomes pale, sweating, breathing rapidly, saying they feel weak or like they might faint. Their blood pressure falls to dangerous levels, hands and feet grow cold to the touch. The heart continues to beat, but it is failing at its essential job, pumping enough blood to keep the organs alive. This is cardiogenic shock. It is one of the most serious emergencies in cardiology, and even today, it can be deadly if not treated quickly. First, let's clarify what shock means in medicine. It's not about surprise or distress. Shock refers to the body's tissues not getting enough blood and oxygen. Multiple paths can lead there. Losing a lot of blood or fluid causes hypovolemic shock. A massive infection that dilates blood vessels results in septic shock. A severe allergic reaction causes anaphylactic shock. Cardiogenic shock is different because the core problem is the pump itself, the heart. When the heart fails to push out adequate blood, every organ, the brain, kidneys, liver, lungs, receives less oxygen and begins to suffer. Picture the heart as a four-chambered pump. With each beat, the left ventricle squeezes, forcing blood into the aorta. In cardiogenic shock, that squeeze, what doctors call contractility, plunges. The heart may be damaged by a heart attack, stunned by injury, or mechanically broken. When contractility drops, stroke volume falls, meaning less blood is ejected with each beat. Cardiac output decreases, so less blood circulates per minute. Blood pressure falls, and organs become underperfused and start to fail. The body senses the decline and attempts to compensate. The sympathetic nervous system responds. The heart rate rises, blood vessels constrict to boost pressure, and hormones like adrenaline and angiotensin flood the system. These reactions are helpful at first, but in cardiogenic shock, they can make things worse. Narrowed vessels increase resistance, the afterload, so the weak heart must work harder to push blood out. The result is a vicious cycle, a failing pump facing greater resistance, which deepens the failure. What triggers this crisis? The most common cause is a large heart attack or acute myocardial infarction. If a substantial area of heart muscle loses blood flow and dies, the remaining muscle may be unable to generate enough force. But cardiogenic shock is not limited to heart attacks. It can arise from severe chronic heart failure or dilated cardiomyopathy, from abrupt valve problems such as a torn mitral valve or severe aortic regurgitation, or from mechanical complications after a heart attack like a ruptured papillary muscle or a hole between chambers. Dangerous arrhythmias, very fast ventricular tachycardia, or complete heart block can precipitate it, and myocarditis, inflammation of the heart muscle after infection, is another cause. These diverse problems share one outcome. The heart's pumping ability is suddenly crippled. At the bedside, cardiogenic shock has a recognizable pattern. Patients show very low blood pressure and often a rapid heart rate. Skin is cold and clammy with weak peripheral pulses. Urine output drops because the kidneys are not getting enough blood. Mental status changes, confusion, restlessness, or drowsiness reflect brain hypoperfusion. Breathing can be labored, and sometimes frothy sputum appears when fluid backs up into the lungs. Blood tests often reveal high lactate, indicating tissue oxygen deprivation, rising creatinine signaling kidney injury, and elevated troponin or other cardiac markers when a heart attack is involved. An echocardiogram, an ultrasound of the heart, is essential. It shows how well the ventricles contract and can reveal valve ruptures or holes in the heart wall. Treating cardiogenic shock requires immediate, aggressive care in an intensive care unit or catheterization lab. The first priority is life support, oxygen, and if necessary, mechanical ventilation to assist breathing. Fluid management is delicate. Too much fluid floods the lungs, too little worsens organ perfusion. Vasopressors like norepinephrine are used to raise blood pressure. Inotropes such as dobutamine help the heart squeeze more forcefully. The second priority is correcting the underlying cause. If a blocked artery caused the shock, rapid revascularization through angioplasty and stenting or emergency bypass surgery is critical. Torn valves or structural ruptures often need urgent surgery. Dangerous arrhythmias require immediate correction with medications, cardioversion, or pacing. When medications aren't enough, mechanical circulatory support becomes vital. Devices include the intra-aortic balloon pump, which reduces cardiac workload and improves coronary blood flow, percutaneous ventricular assist devices like Impella that directly augment left ventricular output, and veno-arterial extracorporeal membrane oxygenation or VECMO, which can temporarily take over heart and lung function. These tools serve as bridges to recovery, surgery, or longer-term solutions. Managing cardiogenic shock demands a coordinated shock team. Cardiologists, intensivists, surgeons, specialized nurses, and perfusionists working together. Despite modern advances, cardiogenic shock remains serious. Short-term mortality can range from about 30 to 50%, particularly when treatment is delayed. Outcomes improve with early recognition, rapid transfer to centers equipped with cath labs and mechanical support, and care guided by standardized protocols and experienced teams. For the public, the takeaway is straightforward. Don't ignore chest pain, severe shortness of breath, or sudden collapse. For clinicians, success depends on early diagnosis, rapid revascularization, and timely escalation of support. Cardiogenic shock is what happens when the heart suddenly cannot keep up with the body's demands. A failing pump leads to low blood flow, organ injury, and without prompt treatment, death. But with quick recognition, restoration of blood flow, and support from medications and devices, we can interrupt that vicious cycle and give the heart and the patient a real chance to recover.